I sort of made a few comments about this in brief during my first lecture, but I wanted to share with you why we think this is so important. You know, the issue of race and ethnicity in this country is perhaps of more interest to people than ever before. And in one respect, it makes me happy that there has been a movement. Perhaps it was triggered by the Black Lives Matter, but by other events that have occurred in our country over the last few years. But it has been something we've been talking about in myeloma for many, many years because we've seen that disparity. And I could, again, talk to you for hours about this, but the way I've structured it is I tried to make it simple. I just have a top 10 list of facts that I want to share with you that you may or may not be familiar with. These are the facts that have basically driven us to do this Empower program. And I know that I've purposely not defined Empower in a lot of detail yet because we have a little bit of time to do that a little bit later this morning. But what are these 10 facts? Well, number one is myeloma is the most common blood cancer in African Americans. It's not the most common blood cancer in general. That would be lymphoma and even leukemia. But the incidence is growing, and we're seeing more of it, partly because the African American population is growing here in the U.S. It accounts for about 14% of the population now, likely to be significantly higher over the next few years. And we expect over the next 10 years that almost a quarter of all myeloma patients will be of African American descent. I'll tell you more about that in a moment. As I intimated before, myeloma is twice as common in this, meaning what we call the incidence rate, or the number of people that are diagnosed every year. And it actually even starts with MGUS. We had that excellent question about MGUS earlier, that MGUS, that precursor state, is more common. And by the way, we've done these studies not only here in the US, but in Africa as well, several countries, in Ghana and in other places, and some of the work that I know I do in Northern Africa, we've been noticing and detecting this as well. So it's twice as high. Not only is it diagnosed more, it's actually diagnosed at a younger age. Jelek shared with you his diagnosis several decades ago, and despite his youthful appearance now, we know, of course, that he was very young at the time of his diagnosis. But on average, African American patients are about 4 to 5 years younger than the overall average. In fact, probably the youngest patients that we know of on average diagnosed with myeloma are of Hispanic descent. And we also see this in Latin America. The IMF is doing a lot of work in Latin America, and we do know that on average the diagnosis is made at a younger age. Number four, that as I commented before, whereas 14% of the population are African American, 20% of myeloma patients are of African American descent. And so that means that 1 in 5 patients in this country that have multiple myeloma are of African American descent. And that becomes important, as we're going to discuss a little bit earlier, around access, because many of the places that have these centers, just like we described a few minutes ago about stem cell transplant, that places like Memorial Sloan Kettering do, and they have done as much outreach, doing tremendous outreach out into the community. Often these places and these centers of excellence may not be where people actually are living. And I know this is kind of a funny curve to look at, but the bottom line here is what's circled is that the average survival of individuals with myeloma, if a black person is diagnosed with myeloma, their likelihood of dying from that disease, the time frame in which they're going to do so, is half that of a white person of the same age and gender. And to me, this is one of the most striking differences, that it's not right by any means that in the same country, in the place where you would hope and expect that people can have access to the therapies. And we're going to show you a little bit later that the essence of that disparity has to do with late diagnosis and with access to the right treatments. Which leads me to number 6, which is there's a longer time from the symptom onset to the diagnosis in African Americans. And a lot of that has to do, what we were talking about earlier when the question of diabetes came up, is that people don't come in saying, oh, hi, I have myeloma. They come in saying, I'm really, really tired. I have this pain. I had a woman in my clinic a few weeks ago. She's in her mid-30s, and she had rib fractures. But people didn't take her seriously. They just didn't think that she was kind of dismissed from 2 different emergency departments and in primary care. And ultimately, this young African-American woman was clearly diagnosed with multiple myeloma. And so that delay has lots of causes, and it has to do with the confounding diagnoses that we mentioned, getting access even to basic primary care, let alone the fancy schmancy drugs that we talk about in myeloma. It's sometimes because of the awareness of the primary care doctors that they don't think of myeloma If we don't think about myeloma, we're not going to do those specialized tests to look for that abnormal protein in the blood, and often a lack of timely referral to specialists. Amy may mention that I like the use of the letter T, and so there are actually 4 T's, but 3 on this slide, that we know, unfortunately, when it comes to access to care, that African American patients in this country, and you may hear me using the word African American and Black, they're not absolutely intertwined, of course. You know, as I say, I'm African American but not Black. There are individuals who are Black who may not identify as African Americans. We think of it as both a genetic and a social phenomenon, and we look at both of these groups together. They're less likely to receive the T's. These are 3 things that we know have improved that survival in myeloma that I mentioned from the start, which include what we call triplets, or 3 drug combinations, transplants, that very thing that we were just discussing, where people can get a treatment that can improve their survival with myeloma, and then more recently, this new treatment that Dr. Usmani is going to share with us in a minute, because he's one of the world leaders in this field of what we call CAR T-cell therapy, where we can actually take T cells out of a patient and manufacture them in such a way that we basically give them super soldiers back for them to attack their own disease. And the 4th T, which is topic number 8, is that clinical trials, and Dr. Usmani and I are actually going to have a little conversation about clinical trials towards the end of our session today, and what they are and why someone would want to be involved with them. And we know that sadly, historically, although African Americans, as I commented, are about 20% of all myeloma patients, at best, we've seen participation around 8%. There are also some biological differences. You know, someone said to me once, well, Dr. Joe, if African Americans have what we call inferior outcomes or shortened survival with myeloma, is it just because they have a more aggressive form of myeloma? Because there are other cancers that are more aggressive in different populations. We see this in certain forms of breast cancer and colon cancer. But you know what? It's actually the opposite in myeloma. That when that question came about, are there different types of myeloma? And I said, some people have what we call standard risk, some people have high risk. That high risk is a more dangerous form of myeloma. In fact, African Americans are less likely to have high risk. So to me, this even widens the disparity, because it tells us that the poorer survival is not because of a more aggressive biology. And for those who like these numbers and letters, I know it looks like a bit of an alphabet soup here, but what we do is when we take those plasma cells and test them out of the bone marrow to know that someone has myeloma, we don't just count the plasma cells, we actually look at them really carefully to see how aggressive they are, and we look for those genetic mutations or changes in their blood, and we know that there are certain changes that are particularly important. There's something called translocation 1114 or T1114, and we know that interestingly this is more common in African Americans, and that translocation 1114 usually means that people are actually going to do better with myeloma. And we're actually even developing treatments that are very specific to translocation 1114 that we think are really going to benefit these patients even more. By contrast, there are things that are quite aggressive, things like 17p deletion on the other side, which means they're missing a chromosome that normally is really helpful to the body, and that's less common in African Americans. So the answer to the disparity is not the biology. And then perhaps lastly, and maybe even most importantly, is that we've looked at different studies like in the VA system, for example, where at least theoretically, everybody's given the same treatment. We've learned that African American survival is actually better than those of different races and ethnicities. And so this is the reminder that we can do something better. This is the reminder that if we can find a way to provide that accurate diagnosis and provide that treatment in time, the right kind of treatment, that people, African Americans with myeloma, should actually be living longer than white Americans, let alone such an inferior difference. And so what can we do about it? And that's why we're here today. This is my last slide before we take a little break, that it's a complex solution, a complex problem that takes a complex solution. But one of the reasons we've tried to gather the individuals that we are here today is that we think that it requires all of these 3 levels, that it has to land in the lay public, as it were, that we need to raise awareness, that we provide education, that we advocate and even empower just in the community in general. This is one of the reasons why, as I'll show with you in a moment, that in the Empower program, that's exactly what we're trying to do. We'll partner with churches, fraternities, sororities, non-medical and medical. We'll partner with the National Medical Association, Black Nurses Association, you name it. We'll partner to go into the community and educate people about myeloma. But also in the medical community, we need to understand this better. We need in the primary care community to enhance an earlier diagnosis, but also in the hematology oncology community, that we understand culturally sensitive care, or cultural humility, being able to listen better and understand the needs of the patient. I'll share with you in a moment, or later in the session, one of my favorite programs that we've ever developed, which was a medical student program. We take minority medical students, many of them from historical Black colleges and universities, and pair them with myeloma doctors to do a project in health disparities, so that we can breed a new generation of myeloma doctors who are understanding of this and can provide optimal care. But also, if you're here from the corporate community today or from the regulatory community, we need help and support there too, that we have to look at some of the things, the drivers of that disparity. You know, that the drivers start from as high as systemic racism, the way the healthcare system works, the way the social determinants of health cannot be ignored in this kind of process. And those are things that we'll talk a little bit about later. But it really does require collaboration from all the stakeholders, and no one place can fix it all, that's for sure, but we do think the IMF is poised in a unique place at the juncture of all of these groups to try and at least shepherd us along and guide us along so that we can make a real difference. And just being here today means a lot to us for that. So we are definitely in time for a little bit of a break, so you can get up, stretch your legs, get a little bit of a bite to eat. The one thing I'll ask you to do before we head to the break is on your tables are a QR code that something has been created called That's My Word MM. That's the website if you wanted to go to it as well. That's My Word mm.com, and if you make a promise or a pledge to help conquer myeloma, to do what we've been discussing today, a donation actually gets made to the IMF. So that's even just stating that you want to fight myeloma, that you want to make a promise to reduce these health disparities as we've discussed today. So maybe you can do that as you get up to go to your break. Let's come back in about 15 minutes, so just a little past 11:30, we'll come back and join together to continue the day. Thank you very much.